Hi, good afternoon, everyone. This is Mary Foley, and I'm really pleased to welcome you to the second Safe and Common webinar, The Unfinished Agenda. I'm very honored as chair of the Safe and Common campaign to welcome you to this seminar. I'm a registered nurse. I've been working on this topic since the mid-'80s. And look forward to engaging our wonderful team of presenters that we have with us today. The Safe and Common campaign, and we're working on our slides right now. Just do it manually. So we'll send Jasper a quick note. We're having a little slide issue here. There we go. Keep going. No. So that's a old picture of me, but I won't give it up. And if any of you want to know more about any of the presenters today, there is a bio section that is available about all of the speakers. So we're going to be fairly brief in our introductions of our speakers today, knowing that you have the opportunity to see that additional information on your own. The Unfinished Agenda is really a topic that we started discussing a year ago. And as I mentioned, this is our second webinar. We held one on November 14th in 2012. That is available for you. It is archived at the safeandcommon.org website, which we've provided for you on this slide. Basically, we're re-engaging a nationwide and actually an international conversation on sharps and needle safety protection. Some work has been done, not enough has been completed, and that certainly will come alive and very clear to you in today's conversation about some very unmet needs. So those are our program objectives. The opportunity for you today to participate, we thank you very much for registering, for logging in, for listening in, and I hope you will take a look at that archived presentation if you weren't with us in November. We have a number of participant consoles that are available to you on this presentation website. And so, as I mentioned, there are speaker bios that you can take a look at a little more detail about each of the presenters, resources that are available that are supporting documents regarding this important topic and some of our speakers' presentations. We're in the slide presentation now. You are welcome and invited to participate in a Q&A session using an online question and answer protocol. And anytime you want to ask a question, we look forward to responding to those. Very likely we'll compile them as we did last time. We had really hundreds of good questions. We compiled them and answered them in a thoughtful and timely manner using the Safe and Common website. And of course, in this modern age, we use our social media. So let's move very quickly to the topic for today. We're focusing not just on the general overall topic of sharps and needle safety. While very important, that was quite a bit of our presentation in November. Today's agenda is focused on some of the areas that remain particularly unaddressed, that being the surgical area and the non-hospital settings. Those remain underrepresented in terms of the devices, the strategies, the protocols for safety. So you will hear from speakers who are expert in those areas today, and then certainly we want to continue to engage all of you in that conversation as time goes on. What I'm excited to do now is show you the first poll question. We want to have your active engagement and participation in this webinar, and part of the way we structure our next programming will be in regard to your response to this important question. You can see the slide now. Please answer appropriate to your particular orientation. Does your institution utilize sharps injury data in making purchasing decisions for medical devices? Please answer now by checking one of those boxes. We'll take an opportunity then to let a few of you vote very quickly, and then we will show you the results of that very interactive poll. And that's in advance of my introducing our next speaker. And already we're beginning to see some responses, and it's actually quite positive. We're going to send that out to you. We're going to push those results. We can see them. We're going to push the results to you. A large number of you are commenting that you are seeing this data used in decisions regarding medical devices. I think that's actually kind of encouraging, particularly since our first speaker is Angela Laramie from Massachusetts. And Angela is going to talk to you about data, the importance of it. And Angela, I'm going to turn it over to you and have you start our first segment.
Great. Thank you very much for including me, Dr. Foley. Thank you, everybody, for taking the time to participate in the webinar. I'm going to build off of the previous webinar discussion where the importance of using standardized data was covered. And I just want to mention, I'm not intending to review Massachusetts data necessarily, although the slides you will see are from our surveillance system. My intention is to share with you the ways that data can be used, basically how to slice and dice the numbers. I encourage questions later. You'll see some contact information for me as well. I just want to remind you, though, as I'm showing you the graphs of statistics, that these statistics really represent individuals and families who have been affected by Sharps injuries. And as Irving Selikoff, who studies asbestos, said, statistics are people with the tears wiped off. So I think it's important to keep that in mind. Next. Go to the next slide, please. So how can you use your Sharps data? Well, you can look at trends over time. You can look at rates versus counts. Oftentimes we do proportional distribution with that count data. You can use it to make purchasing decisions, as was asked in the recent poll question. You might use your data to identify where you need to make changes in practice or changes in process and systems. You might identify areas where additional training is needed, and you might also identify devices or procedures where in-depth investigations with injuries occurring during those procedures might be necessary. It's not possible to do root cause analysis on every injury, so I recommend that people pick one, and we'll talk about that a little bit later. So now that you've gathered the data, how will you use it? Well, I just want to show, if you could go back, please. I just want to show you that, if you could, thank you, that it's important to look at rates as well as accounts, and it's important to choose the right denominator to make sure that your denominator most closely reflects the risk. We happen to use the number of licensed beds, as you can see on the right-hand side of this graph. Beds are okay, although it doesn't capture the risk in the emergency department of the OR. You could use employees. You could use devices. If you're looking at injuries in the operating room, you might want to look at the number of cases. If you're looking at injuries in your emergency department, you might want to look at the number of ED visits as your denominator. But there's no one best denominator. I also want to make a very quick point about benchmarking. Massachusetts data is not intended to be used as a benchmark. It's a snapshot of the Massachusetts experience. You really need information about process and practice in order to use data appropriately as a benchmark. And it's really best to look at your own data over time. Next, please. So here is a slide demonstrating the importance of using rates. When we did proportional distribution looking at the counts of injuries, we found that back in 2002 through 2009, most of our injuries were occurring among nurses, followed by physicians. However, when we looked at rates and we used employees, and I realize not all physicians are employees of a hospital, but for those physicians that are, we were able to calculate rates. And we could see that the rates of injuries among physicians was not only higher than nurses, but also increasing over time, where the rates of injuries among nurses were decreasing. If we only looked at the frequency distributions, we might focus on injuries among nurses, but looking at rate data shows us that we need to pay attention to injuries among physicians as well. Next, please. The next slide will talk about how you might be able to use data to influence purchasing. So this slide, while I recognize that it's kind of busy, it does show you the proportion of injuries occurring with devices with Sharps injury prevention features. Those are what we call CSIPs, the OSHA acronym. And those are the green and white bars. And the proportion of injuries occurring with devices lacking Sharps injury prevention features, or those non-CSIPs, that's the red bar. And the yellow represents where we don't know whether there's a Sharps injury prevention feature. So you can use this to identify devices where there's need of conversion to safer products. You can see that in the scalpels. We have a lot of injuries occurring with devices lacking Sharps injury prevention features. You might take a look at the manufacturers. You could break this out by manufacturer within those red bars or the green and white stripes. You could look at the mechanisms of Sharps injury prevention features. So looking at injuries for winged steel needles, we see that most of the injuries are occurring with devices with Sharps injury prevention features. So what do we know about those mechanisms? Do we need to change which mechanism we're using? Again, you could use this to identify which incidents to do a root cause analysis. Maybe you want to look at the hypodermic needle and syringe. Maybe there's problems with the injections. So you could decide to identify those injuries and do further investigation. I want to make a point about the importance of unknown in this graph. You may have seen this graph or data from Massachusetts presented previously without unknown. I think it's really important to include because it says something about data quality. You can see, particularly looking at scalpels, that in 2002 and 2003 we had a fair number where we didn't know whether it was a device with a Sharps injury prevention feature. But reporting and the data quality over time has gotten better, and that unknown has decreased. So I think that's really important to include as well. Next, please. When we look at data over time, we can see using both rates and proportional analysis, and this is just looking at injuries with hypodermic needles and syringes. And again, the red and green representing the devices with Sharps injury prevention features and without. If we look at this as a proxy for use, then this would reflect exactly what we would expect to see, that as we increase the number of devices used with Sharps injury prevention features, most of our injuries are going to occur with those devices. So that's what we're seeing. We are also seeing at the same time a decrease in the injury rates over time, and that's a really good thing. So that shows us that the devices are doing their job, but they're also not enough. And so it's really important to make sure that you have a comprehensive program that includes employee involvement in device selection. Dr. Fisher is going to talk about this later. That you do training on the use of the devices and that you have appropriate disposal mechanisms appropriate. And I just want to mention with this slide what you don't see is that the number of injuries remains steady over time. So about 900 injuries per year with hypodermic needles and syringes, even though we're seeing a decrease in rates. On the next slide, shows you how you might be able to use data to identify systems changes. When we look at when injuries occur as well as how the injuries occur, and we group those how events into the when categories, which this slide does, most of the injuries occur after use. And so you might want to focus your prevention efforts on after use. Activating the mechanism, the safety mechanism, does that mean you need a better device? If the injuries are occurring during cleanup, do you need to change your protocol? Some hospitals have instituted a process where if a doctor uses a device in the emergency room, then the doctor, not the nurse, is responsible for cleanup. And they found that that's had an impact on reducing injuries. The locations of disposal containers, when we look at during or after disposal, some hospitals have come to look very much like hotels, and there's very little clinical apparatus around. And with that goes with putting Sharps containers inside cabinets. You don't want to have to go look for a disposal container. And then during use, you might want to look at, well, it's not shown here, passing equipment, hands-free and neutral zones might be used in the operating room. So these are some ways that you can identify what changes you might be able to make. I'm happy to talk with anybody after the webinar and hopefully given you some food for thought. So thank you very much.
Thank you very much, Angela. You have wonderful clarity around your presentation, and we think you're probably going to be one of our special experts to do some data programs standalone. It's really very interesting and a lot of good questions coming addressing your content. I'd like to introduce then Dr. Hyman. We're very pleased to have him with us today. In fact, he was an individual who submitted an abstract after our first webinar, and we are thrilled to have his content included today. And you'll hear about our call for abstracts for our next session in May. Dr. Hyman, please take over.
Thank you. And as an engineer, I'm going to focus on the device design in particular. And in the next slide, following on what I think is the excellent data and analysis out of Massachusetts, is my desire to see a finer look, a more granular look at the timeline and in particular at what devices are being used. If I could have the slide, please. So in particular, I divide the syringe arena into kind of pre-use, use, and post-use, and we just heard about the post-use problem. I think it's interesting that there are products aimed at the pre-use or pre-patient arena, but I don't think those are particularly important. There are in-use injuries that hardly any safety devices actually address, except perhaps needleless. But then we move rapidly from the end of the injection into the post-injection period, and that's where safety devices, for the most part, are supposed to be protecting users, and where, unfortunately, they often are not. Next. So if we are familiar with syringe needle safety devices, we know there are a variety of designs, a variety of execution of those designs. They have different operational features. Some of the old ones are clearly two-handed. There are some that are claimed to be one-handed, but perhaps aren't really, especially in real use. And then there are ones that are really one-handed, meaning you don't have to reposition the hand. So with these multiple devices that are out there and the ongoing problem of sticks, the question is, are all of these safety devices equally safe? And I think the answer is no. So in the next slide, we want to ask in a more focused way, why do these transition and post-injection sticks actually occur? And I think the answer is that the devices are theoretically capable of covering the exposed needle or retracting the exposed needle, but in the real world of clinical use by real users, this does not happen well, or it does not happen at all. And then the question is why? And I think part of the answer is that some of these devices are actually too difficult to manipulate and activate safety, so that the actual attempt to use them produces injury instead of preventing injury. Following on that, and this assumes a reasonable level of training and discipline, some are not been found not to been activated at all. And the reason is multifold. They may not be intuitive, so that the training didn't take, or they're actually, the first problem is recognized by the users that they're actually dangerous, and therefore the users deliberately don't activate them or attempt to activate them because they don't want to risk the injury of doing so. So while the conference room is a good place to start the process of device selection, as we'll hear next, it's not the place to end device selection. And so we need real-world safety, not just theoretical safety. So in the next slide, I ask the question for all of us, well, what do we need to know to identify those devices that work and those that don't? And we just heard, and I echo, we need to know exactly why and when sticks occur on a finer scale. What was the person doing exactly when they got the stick? And we need to know exactly what product was being used so that we can begin to understand whether there are products that work and there are products that don't actually work. And then associated with that is, why did the product that's supposed to be a safety device not achieve safety? And if we look then at the next slide, we also need to emphasize not to blame the user. And so what this little graphic suggests is that the whole needle stick arena, and probably the whole sharps arena, goes back to the problem of use errors, and that we blamed the user and we told them to be more careful. And ultimately, we collectively decided, well, that doesn't work. What we need is safer devices. So then we get safer devices, and if we have sticks anyway, what do? We blame the user back where we were before, instead of asking the questions that I've alluded to here, which are, why isn't this safety device producing safety. Thank you.
Thank you very much, Doctor. It was a very excellent presentation, and thank you for submitting your abstract. I'm pleased now to introduce our next speaker, Dr. June Fisher. She's certainly a pioneer in this area, and I'm going to have her start by telling you about TDICT, which is an acronym some of you may be familiar with. And June, thank you for joining us today and all your work.
Good morning, Mary, and the whole participants. This is a very exciting event happening, and I look forward to more future presentations. I will be extremely brief. I will mention that I'm not going to present specific instruments. They are available, most of them, on our website, and those that are not will be shortly available. The TDICT project is a unique project that was founded in 1990, although I would preface that my interest in safe use of sharps goes back to 1979. But the TDICT project was founded in 1990 and is a collaborative effort of healthcare workers, product designers, and industrial hygienists dedicated to preventing exposure to bloodborne pathogens through design and evaluation of control technology. We had long been interested in having safer devices, which were not available to the late 80s and early 90s, and it was clear that they were not addressed really for safety, and we developed this project. It is a project that strongly involves the participation of the frontline users in all phases of the design process for the development of medical devices, because the users are the ones who really know how they're used and have the concerns about both patient and healthcare worker health and safety. The user design process should, as I said, should involve the healthcare worker and the purchaser from the very beginning, from even need finding, because who better knows what the needs are, and through the whole process. I think if this was really followed, and I know that there's a lot of discussion about user-based design, most of it does not start from the very beginning, but if it was, I think we would be having better devices. As was clearly stated before, many of the devices are not that good. They're not even addressing the needs. But because of the time constraints now, I'm going to just focus on selection and pilot testing. I would like to make the point that there's a need for systematic methods for the user-based evaluation. And while the next chart will look complicated, once you set the system up, it goes very rapidly, and you can do your annual reviews easily by using the system if you set it up systematically. The TDICT protocol has two efforts. One is usability and efficacy. We have focused on our work in terms of usability, but I would like to, later we'll discuss more of efficacy. Efficacy is basically pilot testing in the workplace, and I think that most of us would agree that it's not generally well done and it's sporadic, and I will come to that before. But I would like to start out saying is task analysis, an instrument that will be available on our website shortly, is a way of analyzing what you're doing, where you're doing it, and who's doing it. This is a critical feature, not only for needle stick things, but for anything that you're doing. This is, like, I consider the master that really gives you an insight of what you're doing. So you start with your task analysis. But then when you're looking at specifically a class of devices, you go to a screening procedure. This is a tabletop procedure. And in this, you want to get every device that's available in that area. And it takes a little effort. So you got to call companies. You got to look at catalogs, but it is doable. And you should not screen when you're initially starting this. And, I frequently say that I love bad devices. Why do I say that? Because if I'm looking at a bad device, it really hones up what I don't want to have in a device. But after you go through screening, and you should use systematic criteria sheets, most people are using the TDIC criteria sheets, which are now available on our website for a host of specific devices. And then you go through that, and at the end you'll pick out 2 or 3 or 4 that answer your own needs. You go to failure analysis. What do I mean by that? Ask the manufacturer for 100 devices and sit at the table and just see how often they fail. You will find that your numbers for failure probably are far greater than the numbers that are submitted to the FDA. And again, you'll end up 1 or 2. So you want to do exactly what Dr. Hyman says. You want to look at it in a more clinical context. And this is where you, based on your task analysis and using scenario hints that are on our website also, you can create the specific clinical context where you will be testing them. You're not testing them on humans at that point, but you're recreating the clinical setting. And after that, you will then, while you're doing this, you should build into your scenarios failures. And Mary Foley, who you all know now, is a long time as our senior nursing consultant, and we've worked together for many years. And I always say that when Mary does a scenario, she has very poor technique. That is, she builds in all the anticipated things that might happen, like dropping things on the floor, hitting them against bed rails, and similar devices. And by that point, you can get a fairly good idea of what the device that would be appropriate for your particular needs in a clinical setting. And I would just like to say that the ideal device would be one that's passive, it's easy to use, and it's simple. And simple and easy are different things, and that the protection lasts throughout. A device where the safety feature does not last permanently is a very dangerous device, because your colleagues will assume once it's engaged that it's safe, and we do know things just end up sometimes lying around, so that you have to make sure about that. I would like to talk a little bit about pilot testing. And it's at this point a conceptual framework. I think most people will agree that pilot testing is generally sporadic, it's very demanding, and that frequently you don't get every device used. What you do get is 3 or 4 weeks later a consensus group talking about the device. And you may have people participating who have never used the device because they've been resistant to it. And I would like to propose a concept of having a collaborative effort. That is, that we engage a number of hospitals who will do the pilot testing systematically using criteria that would be developed by a consensus group. Further, I would say that this national consensus group publish their data so that manufacturers will know what is going to be anticipated, what they're going to be looked at, that the FDA will further incorporate this into their approval systems, and that all hospitals, both on a national and international level, could use the final data. I would like to make the point that it's important that each device be recorded at the time of use. How can this be? If we limit our consensus data to 6 to 8 questions and put them on mobile devices, I think we can get healthcare workers, to very, very busy healthcare workers, to submit that data. We can then pool that data because we'll be looking at the same things, and I would say that if we have a good biostatistician to tell us how many trials we need, probably within a month or 2, we would have a very clear understanding of what's a good device and what's not a good device. I have the hopes that this kind of systematic testing will push the manufacturers to really give us good devices. We've had improvement in devices, but we still have a long way to go.
Thank you so much, Dr. Fisher. That was fantastic. And at this point, I wanted to say two things. One, clearly there's more content that we could cover in just today's webinar, and we will be scheduling a standalone webinar with Dr. Fisher for more detail on TDICT and the process that has been so well developed and refined. And also, we're inviting industry sponsors. This is, I think, an opportunity for our industry partners. Many of you are on this call or keep an eye on Safe and Common to perhaps participate in this process of developing a consensus and helping support this large-scale testing. It will move the agenda forward, so I thank you for raising that. Right now, we're ready to do another poll, which will really set up very nicely our next speaker and the panel of speakers from the Association of Operating Room Nurses. So the poll that you'll see, really, if you are an operating room person or purchaser, please answer all that apply in this case. This is an opportunity for you to vote for more than one, and so we'll let you indicate your selection, and then we'll start to push the results out to you. So it's really not a either or. This is exciting to see that there is a range of activity around the use of preferred either procedures or devices, and now's the time to hear more about that. It is my privilege and pleasure and certainly an honor to introduce to you Mary Ogg from the Operating Room Nurses. She is an expert in this area of policy, and I'm thrilled to have her and her panelists speak to you at this time. Mary, please take over.
Thank you, Mary. ARN is grateful for this opportunity to share what we have learned about sharps injury prevention in the OR. During the Safe and Common webinar in November, participants identified the OR as a challenging area for sharp safety, and the statistics support this. Can I have the next slide, please? As you can, Jagger and al. Analyzed sharps injuries before and after the passage of national needle stick legislation. And as you can see, rates outside of the operating room dropped significantly, which is wonderful, but our surgery rates did increase by a slight amount. 30% of all sharps-related injuries happen in the OR. Suture needles account for 43% of our sharps injuries, followed by scalpel blades at 17% and syringes at 12%. Next slide, please. The OR is at an increased risk for sharps injuries, and this is because we are a blood-intensive environment. We use very sharp instruments, and there are complex interactions among the surgical team. We share the risk of sharps injuries in the OR. Decisions made by one team member may affect the entire surgical team's risk of injury. Surgeons and residents were most often the original use of injury-causing devices, and whereas nurses and surgical techs were typically injured by device used by others. And I think we have another poll question coming up here.
So this,
go ahead, Mary.
Okay, we got two Marys at the same time. So this supports the focus on the perioperative area today, and we wanted to get a better idea of your participation if you are in that area or perhaps in the purchasing arena for how do you influence purchasing in the institution. So now's an opportunity for you to vote and give us some feedback on this, and we will start to push these results out to you so that you too can see. There you go. So getting some feedback, Mary, on the frequency of activities in terms of the influence on selection. Very good.
So now it is my pleasure to introduce our OR panel of experts, and we have decided to present our material in this format as a Q&A. But first I'd like to introduce Donna Ford, and she is the chairman of AORN's Clinical Nursing Practice Committee, and we have been developing sharp safety resources for the last 3 years. Next slide, please. And also Deborah Spett is our current AORN president, and she has been a workplace safety proponent for several years with a particular interest in sharp safety. So Donna, our first question is on double gloving.
Well, thanks, Mary. So what is the evidence and why should I double glove? Well, it's easy to say there's lots of good evidence, good solid evidence about the benefits of double gloving. There is a Cochrane review, which, as you know, is the highest form of evidence, and that already shows the benefits of double gloving as a way to protect against needle sticks and sharps injuries. We know that wearing 2 pairs of gloves reduces the risk of glove perforation and percutaneous injury, thereby reducing or minimizing the risk of bloodborne pathogen exposure. We know that when 2 pairs of gloves are worn, a lot of times, in most instances, only the outer glove is punctured. Also, when 2 pairs of gloves are worn and a puncture occurs, the volume of blood on the puncturing device, which, such as a solid suture needle, is reduced significantly by as much as up to 95%. So the actual blood exposure is less. We know that physician groups, as well as AORN and others of the medical community and the nursing community, are very strongly in support of using evidence, and they base their recommendations on the evidence. And so, along with AORN, the American College of Surgeons and the Association of Surgical Technologists and the Council on Surgical and Perioperative Safety have all endorsed the use of double gloving as part of their sharp safety initiatives. One other thing is a person in practice should always monitor the integrity of their gloves. As they choose to double glove, always keep an eye on how the gloves are doing. Now, I wanted to answer the second part, the why should I double glove? And I would like to counter that with why not? It really significantly reduces your risk of exposure to bloodborne pathogens and the risk of surgical site infection for our patients. So why would we not want to protect not only ourselves but our patients? Okay. The next question is about the neutral zone. And how do you implement the neutral zone concept? Well, we know that most sharps injuries occur during passing, and that the method of passing of suture needles and other sharps between team members, when we do that, a neutral zone is actually where we don't pass them hand to hand. So it's actually placing the items from one in a zone called the neutral zone or the safe zone, and also called no hands passing. And we can significantly reduce the injuries that way. Now, we know that there is less evidence to support the use of a neutral zone, but the intent with this is that however the team decides to use it, that no 2 people touch the sharp at the same time. So as mentioned, the needle holder, scalpel, or other sharp instrument is placed in the designated location by one team member and then picked up by the other member. OSHA, American College of Surgeons, AORN, AST also all recommend the use of the neutral zone, and Joint Commission recently published a monograph on patient and worker safety in 2012 and said to recommend or to avoid hand-to-hand passing of instruments. So how do you implement it? Well, first of all, you have to have management support. If you don't have the management support, it will be difficult to follow through. You need to have champions, and a lot of times we talk about having one champion. I recommend having champions in all categories of team members, from your surgical technologists to your RNs to your surgeons to your anesthesia providers. From there, you need to have education on how to do a neutral zone and even practice on how to do a neutral zone, and make sure that people can clarify with each other how the process will work. Are they going to pass back and forth in both directions, or is the scrub tech going to place the instrument down, surgeon pick it up, or surgeon, have it hand passed to the surgeon and then the surgeon return it? It depends on the type of case. The neutral zone is something that can't probably be used in 100% of the types of cases. There are some, such as microscope cases, and others that makes it difficult. The team needs to be able to provide feedback to each other. How did this work? How is the neutral zone going? Or can we do the neutral zone on this type of case? And really, ideally, use of the neutral zone should occur at the briefing. This is when they would discuss those situations, such as when you're not able to use the neutral zone or may have to limit the passing of the surgeon. Maybe the surgeon will have to have the instrument passed directly to their hand and not pick it up out of the neutral zone. Lots of choices are available for how you create your neutral zone, and I also recommend a verbal notification of a sharp coming, so that you're speaking to each other. So there's a lot of information about how to create a neutral zone. A lot of it has to be improvised, kind of developed within your own team in your own perioperative setting so that you know what works and what doesn't work. Next, Mary.
Yes. Okay, Deb, I think the next question is for you on the use of blunt suture needles.
Right, Mary, thank you very much. Again, going back to the Cochrane review that Donna talked before, they talk about the fact that using blunt needles versus sharp needles reduces the risk of glove perforation by 54% and reduces the risk of infectious disease transmission. So those two pieces of evidence should be certainly the basis of trying to roll out the implementation of blunt suture needles. We've talked a little bit about the AORN toolkit, and some of the things that are included in our toolkit on sharp safety are the American College of Surgeons statement on blunt needles, and they do support that initiative for closure of fascia tissue. And there's also an implementation plan for trialing blunt needles that's included. And Donna talked a lot about trialing the neutral zone or neutral zone products. AORN has a step-by-step process for organizations to use as part of this, not only the educational tools, but also how one actually implements. Because, when we're trying to trial something new, it's important that we educate. Physician champions, especially when it's a physician-used product, are very important. You need to remove all the other products that would be have the same use, and then getting feedback from the individual users. Dr. Ramon Berger, who is also part of our committee on our nursing practice, has been very helpful. He's put out a educational PowerPoint for surgeons to use, because we know that our surgical colleagues and the residents and the other first assistants that are used need to also buy into change in order to make it happen. We have FAQs in our toolkit, and ambulatory surgery has their own specific, an example of a sharp safety plan for use in freestanding surgery centers, because it's not only important to be implementing these products in inpatient operating rooms, but also in ambulatory surgery centers and the outpatient surgery setting, which is, our surgical procedures are moving to both of those areas. On our next slide. We should evaluate yearly. At least that's what OSHA tells us. But we know that one of the high scream items in the OR is safety scalpels, and that's an item that we need to be looking at constantly, so that the newest and the greatest products are evaluated by the surgical team. So that may happen that may need to happen a little bit more often, because certainly that comes out on an ongoing basis. There's always something new that we see out in the literature. And we know that all the team members have to be involved anytime we do evaluations. Very important that Donna has spoken about it, and so have our other speakers. Cost considerations are something that everybody is thinking about these days, but that cannot be the only reason that we don't move to a safety engineered devices. So as we're taking a look at evaluating all of the different products that are available to the OR, the process is the same, but it's important that as new products become available, And if it hasn't already been implemented, if you don't have something in place to use, that you take a look at device evaluations. And again, one more time, just to reinforce the importance of champions and the importance of the team being involved. Thanks.
Thanks, Deb and Donna. So in summary, I just want to say that the OR is one of the highest risk environments for occupational exposure to bloodborne pathogens. I didn't know there was another poll question.
That's not yours, Mary, so I think we just pushed a little fast. It's okay.
Okay. All right. Sorry. So as we discussed, the double gloving, neutral zone, and blunt suture needles and safety devices are based on evidence that they will reduce injuries in the operating room. And we have resources. ARN has several sharp safety resources, primarily now being the recommended practice for sharp safety. It uses evidence-based practices to help our frontline nurses change what is within their control and to help educate other team members about this. And as Anna and Deb both have alluded to, we have a Sharp Safety Toolkit, which is a free member benefit, and it was developed with members from the entire surgical team, our perioperative nurses, a general surgeon, and a surgical technologist, because we are a team and we work all together. But it includes educational PowerPoints, there's sample policies and procedures, and there's just several resources there that would help implement sharp safety in the operating room. And this spring, the ARN is developing a sharp safety video that will be filmed and will be released later in the year. So as Donna alluded to, we do have the support of our member organizations that work with us around the operating room table, the American College of Surgeons, the Association of Surgical Technologists, and we are moving forward to reduce sharp injuries in the OR. And we did have a question that came up about the correct type of gloves to wear in sterile processing. I think I'm going to punt this one over to Deb, since she has responsibility for the sterile processing department at her facility.
Yeah, I saw something not too long ago, Mary. People were talking about whether or not it was necessary to double glove, and the people that work in sterile processing should not be using regular surgical gloves. They should be using the gloves that are heavy duty and that come about 3/4 of the way up to the elbow in order to, as part of their PPE. So it's not surgical gloves, but there are specific gloves for sterile processing. They're the thick, it's like, and I don't want to use a particular name, but certainly like the gloves that one uses to wash their dishes at home, but that come up farther than that particular brand.
That's great. Thank you for responding to that so quickly, and that's a good reference for everyone. I hope you will take a look at the AORN toolkit. I really respect and honor the work that your association has been doing. And thank you, Mary, and your panelists for participating today and all the hard work that you're doing. At this time, we do have a poll question. We're going to ask you our last poll and push this out to you. And it really is a specific question about last year's participation, whether or not you participated in your institutional exposure control plan process. And so we're going to send this to you, and you're going to answer it, and we'll show the results real quickly. And actually, we thought there might be some that were not applicable because we do have some faculty and others on the line. But not bad for those of you that did participate. You're still voting, and we need to push these results out to you. I'm viewing them first, and Roger's sending them to you now. But there's still a lack of folks who are actively participating, and we want to make sure that this is encouraged and promoted. So I'd love to introduce our last speaker, Elise Handelman, who's very well known to many of us who worked closely during the needle safety campaign, and Elise was formerly with OSHA in the Division of Nursing and a real friend and colleague to this topic. And Elise is joining us by phone, so I'm going to advance her next slide and let her know that we're ready to have her speak to the non-hospital areas, what we're calling the alternative sites. Elise, welcome.
Thank you, and thank you everybody for hanging in. As the last speaker, I know I'm the last one between you and the door, so I'll try and be timely. I appreciate the invitation, Mary, and yes, I was the former director for the Office of Occupational Health Nursing at OSHA. I just want to make sure that everyone understands I'm not speaking on behalf of the agency today. So with that, I'll move on into the first slide. We're talking about alternative sites here, and this is an area that is just, in healthcare, is just booming, as many of you know. The whole area of home health care, outpatient centers, which Mary Ogg and her group have already talked about, the surgery centers and so forth being a site for attention to sharp safety. Private offices, physicians' offices, dental offices, nurse practitioners' offices, physical therapy offices, all these places can be potential sites for needle stick injury. I put long-term care rehab centers with a question mark because so many of them now are affiliated with acute care hospitals that I didn't know how much alternative work they represent. They really, a lot of them are closely tied with acute care hospitals, and yet there's a whole new genre of rehab centers that are coming forward as well that are independent. I listed schools. If you haven't spoken to your local school nurse lately, it's amazing what kind of healthcare delivery is being done in schools. I mean, there are children being mainstreamed who have all sorts of clinical issues going on. There are people that are with trachs. There are children who need insulin. There are just a myriad of healthcare procedures being done in schools. These are really unsung heroes, and if you haven't spoken to a school nurse lately, you may be startled by how much healthcare delivery is going on in schools. And we know that about 40% of nurses are now working in non-hospital settings, such as the ones that I've listed here, and I'm sure you all will think of others. With the Affordable Care Act that's coming forward, some people call it Obamacare, the Affordable Care Act will actually penalize those hospitals for unnecessary readmissions. So hospitals are taking a renewed interest in community-delivered care, and they're being rewarded for what's called with bundled payments. They're called bundled payments, where they actually pay for success rather than procedures. And all of this directs people to, not let the patient go right at the door of the hospital and wave goodbye to them. So healthcare is going to be expanding in the community. If I could have the next slide, I'd like to talk about how these sites are somewhat different. And a lot of this is just common sense. But caregivers are usually operating in a lot of these sites, they're operating solo. There's not someone they can holler out to get help from. They're having to make independent decisions and manage a lot of equipment independently. The environments where they're working are very different. They're what I'm calling uncontrolled. The healthcare provider does not have authority in the environment. In the hospital, the nurse can tell you whether you can come or go or sit down or stand up. But in someone else's home, you don't have any authority over that household. And so there are things with the physical layout may not be acceptable or congenial to what you're trying to do. There may be pets or other animals in the house that are a distraction. The equipment that you need may not be there. So the environment is really uncontrolled and a challenge to work in. The locations, again, may be very remote geographically. They may be spread out over an entire county. And this makes oversight for managers very challenging because they can't get to the work site easily. They're spread out. Purchasing decisions can be far removed from the delivery site. If someone is working in a school, it may be actually the school board who is making decisions about purchasing equipment, which is very removed from the delivery site. A lot of this decision-making about purchasing is centralized. If it's a small office, it may be the office manager or the owner who is making decisions about purchasing, and they may be pretty authoritarian in their decision-making. There are other ways that these sites are different, but I thought these would at least focus our attention on some of the challenges in these alternative sites. In the next slide, I'm listing some of the challenges that I see. in these sites to implementing needle stick safety and sharp safety in general. Education and training is challenging in a widespread location. I spoke to the person who runs the New York City Visiting Nurses Association a couple of years ago. She has literally hundreds of staff spread out all over the city. And we talked about things like, well, at that time we were talking about respirator fit testing, but it's the same thing with training and any kind of training or education. How do you get all those people back to a central location? How do you transport them? Many of them depend on public transportation, so how do you transport them? How do you cover their work while they're gone? It's not the same as just pulling someone off the floor for an hour to do an in-service. It's bringing someone from a remote location in for training, if that's the mode that in which it's delivered. Disposal issues. What about federal and local regulations on disposal of sharps? How do those impact the delivery of care in these settings? Post-exposure prophylaxis is a huge problem in alternative sites because the decision about whether someone needs PEP and how they're going to get their medications and have those delivered in a timely fashion is very challenging. We're talking about, again, remote geographical locations. Not every corner drugstore is going to have the medications that are needed here. Not every family doctor is going to be able to make the decisions about whether PEP is indicated or not for an injury. So these are again challenges for these types of alternative sites. And then the whole selection and purchasing decisions, again, trying to get healthcare worker input during those processes is a challenge. On the last slide, I have a list of some of the resources for alternative care sites, and there are plenty of them. There are online resources from CDC and OSHA, the professional organizations like ANA and AORN just mentioned a great one for outpatient surgery centers that they've developed, so there's information there. Nonprofit groups like Safe and Common or Premier or EpiNet. University of Massachusetts at Lowell has a very nice program on Safe Home Care Project that's available. There's lots of resources. I think the challenge here in moving the agenda forward is to try and reach these groups, not to provide, the information is there. It's a matter of trying to get it to the groups and get them the information they need to reduce needle stick risk. The gap, as I see it, is not in the supply of resources. The gap, as I see it, is in the dissemination and delivery of those resources. One of the solutions I thought might be worth exploring at some point is trying to find and publicize model programs that are based on the elements of the bloodborne pathogen standard, because the bloodborne pathogen standard applies in all of these sites, and use the experience of those who have been successful in delivering those elements in alternative sites. And I think that's an area that would be of interest to explore later. Just keep in mind that the bloodborne pathogen standard applies in all these sites. Even if you're not worried about enforcement, it does provide a best practices model, some of the key elements that should be in a needle stick reduction plan, and that the risk for needle sticks is the same regardless of where it occurs. A needle stick is a needle stick is a needle stick, and we need to work on reducing them and responding to them appropriately when they occur. So with that, I'll turn it over to Mary again.
Thank you so much. That was fantastic, and I think you covered an incredible amount of information. We're at the point where we want to acknowledge the wonderful questions that we've received from the over 800 participants who've been logged in, most of you for the full hour. We're coming to a close. We will be compiling these questions and making sure we give you the right references and resources in a thoughtful manner, so keep an eye on the Safe and Common website and certainly stay in touch with us that way. We are officially announcing our next webinar, which will be at the end of May this spring. Again, we'll be looking for abstracts, and we had a very rich package of submittals for this conference. And what we're looking at in the next session will be more on the concept of the culture of safety, certainly balancing the importance of patient safety with worker safety. And I think Elise really led us very nicely into what are some of the success stories, alternate sites, surgical areas, frontline worker participation. We need to start to stimulate more interest in those best practices and get that information out. Deadline for submittal of the abstracts, March 31st. You'll certainly be hearing more from us about that. So we are looking forward to that opportunity to engage you further. One of the vehicles we're using to show support for the Safe and Common campaign, and really the message of safety for needle stick and injury prevention, is to have you take a pledge. It's available for you at the Safe and Common website. Share that pledge with others. We're almost at 20,000 signatures, and we're just looking to be able to show a widespread national and international show of support for worker safety. At this point, I'm going to look at the last slide and see if there's anything further for us to say. And if not, I'm going to thank all of our speakers today and indicate to you that you have just been an excellent group of experts, very well communicated your topics. I think the participants will express their appreciation, but on their behalf, let me say that it's been an honor to work with you, to engage with you on this important process, and I look forward to future activities together. Let's rebuild this coalition, and let's finish this agenda. Thank you again for all your help and support. We'll talk to you again.